So at the outset, I would want to thank the organizers for giving me this opportunity. And should I share the screen from my end?
Yeah, Shruti, go ahead. Share the screen from your end.
Sorry, sir. I think I'll not be able to do that. I have to log in from two devices to
Yeah,
do some technical.
please share Dr. Shruti's slide from our end then. Shruti, just 1 minute. It will be shared from our end.
No problem, sir. So the abstract that I am presenting is a Chinese study which was published early in this year. It's a cost-effective analysis for the first-line treatment of advanced EGFR positive.
Shruti, slides are shared. Can you see it from your end?
Yes, sir. Yes, sir.
Okay,
Thank you.
good.
So, cost-effective analysis for first-line treatment of advanced non-small cell lung cancer. Next slide, please. It's an interesting study and one of a kind, I must say. So we know that there is a prolonged survival of patients with EGFR mutation positive NSCLC with EGFR therapies, both as monotherapy as well as combined therapies. But there is definite implications of cost in this, and in a real world situation, that is very, very important to find out which is the most cost effective treatment. So this was a cost effectiveness analysis which was conducted to explore an optimal first line treatment in these patients. Next slide, please. So survival data was extracted from 6 clinical trials. We would see which one these were. So these were all which had OS data. Cost related data were obtained from the hospitals and published literature. The effective parameter quality adjusted life year was the reflection of both the survival as well as utility. Then incremental cost effectiveness ratio, ICER, average cost effectiveness ratio, and net benefit were calculated, as well as the willingness to pay, WTP threshold was set from the perspective of the Chinese healthcare system. Sensitivity analysis was performed to explore the stability of results. Intergroup comparisons among multiple trials were done by the Markov model method. Next slide, please. So these were the 6 studies that were included. The Archer 1050 study, which compared dacomitinib with geftinib. The Flora, which compared osimertinib with the standard first-line TKI. NEJ026 study, where erlobev was compared with erlotinib. NEJ009, PEM carbo Jeff versus Jeff, and the NCT 02148380 study, again 3 arms, PEM carbo Jeff versus PEM carbo versus Jeff alone. These were the studies that were included. Next slide, please. So these treatment groups were compared with the control group in each trial, and these were the ICERs, the incremental cost effective ratios, these which were calculated, and the denominator was the poly. Next slide, please. So the average cost effective ratio and the net benefit showed that the combination of EGFR TKI with chemotherapy and osimertinib was of more economic benefit following first generation EGFR TKIs, and sensitivity analysis showed that the impact of utilities and monotherapy could be cost effective with a 50% cost reduction. They were accurate to the sense that they said that for dacomitinib a cost reduction of around 47% and osimertinib a cost reduction of around 51% would actually change the data here, but as of now these are not cost effective if you look at the overall survival advantage that they give. Next slide, please. So first generation TKI therapy remains the most cost effective treatment for these patients, and these results would serve as both a reference for clinical practice as well as formulation of medical insurance reimbursement. Next slide, please. So there were certain limitations to this analysis. It was an inter-group comparison. It was an indirect comparison, and there were definite differences in the inclusion criteria for FLORA, the NEJ study, and there was patients where CNS metastasis was included, while for other studies the CNS metastasis was excluded. Again, clinical characteristics, the EGFR mutation type, the proportion of crossover patients, follow-up time, all of these were variable. Next slide, please. Then there were studies which could not be included because the OS data was not mature. The phase 3 delayed trial, the CTONG 1509 trial. So these were not included. Then studies, they showed a distinction between, like I said, the EGFR mutation subtypes, which definitely influence the survival outcome of the first line treatment. Next slide, please. So to conclude, based on survival data from clinical trials, patients' quality of life, and current costs of medical resources, standard first generation EGFR TKI remains the most effective treatment option for advanced EGFR mutant and SCLC patients comprehensively. Thank you.